Buenas tardes para todos. Bienvenidos a nuestra tercer maxgraft webinar. Hoy tenemos al doctor Frank Kloss desde Austria y tenemos a Suje de Botis también. El día de hoy la conferencia va a ser en inglés, entonces todos en su parte de abajo de la pantalla tienen como un icono de un mundo donde pueden poner la traducción en español, porque esta charla contará pues con traducción simultánea. Entonces, para que todos abajo pueden activar el icono del mundo y tendrán la opción de oírla en español o en el idioma original, que va a ser el inglés. Bienvenida nuevamente a nuestros webinars y nuestro tercer webinar hoy con el doctor Kloss.
Muchas gracias Laura. Buenas tardes Colombia, buenas noches Dr. Kloss. Hoy tengo el placer y el honor de introducir al Dr. Frank Kloss, pues terminó sus estudios de odontología en la Universidad de Würzburg en Alemania en 1997. Después empezó sus estudios de medicina en la Universidad Erlangen-Nürnberg en Alemania. Al mismo tiempo era asistente científico en la clínica de cirugía oral y maxilofacial en la misma universidad. Y después trabajó en la clínica de cirugía oral y maxilofacial en la Universidad de Medicina de Innsbruck y en 2009 obtuvo su habilitación en cirugía oral y maxilofacial y premio Hans Pichler Preis de la Asociación Austriaca de Cirugía Oral y Maxilofacial, y a partir de 2013 tiene su propio consultorio de cirugía oral y maxilofacial en Linz, en Austria, y forma parte desde 2021 del equipo directivo del ITI en Austria. Y pues para las contribuciones científicas no hablamos de nada menos que 69 publicaciones, 6 contribuciones a libros y conferencias. Hoy va a hablarnos de datos concretos, de indicaciones y procedimientos quirúrgicos de los bloques maxgraft y maxgraft cortico. Sin más, voy a dar la bienvenida al Dr. Frank Kloss. Dr. Frank Kloss, thank you so much for being here with us tonight. It's a real pleasure and a real honor to have you. Without further ado, the stage is yours.
Okay. Thank you so much. And I'm really happy to share my experiences with maxgraft, the bone blocks and the cortico, to share it tonight with you. And well, I heard that Jose already told you a lot about the processing of maxgraft, so we get right into the field. And so you already experienced a lot of the granules. This is what I heard. And today we're gonna focus on the maxgraft cortico and the maxgraft bone blocks. So let's start with the bone blocks, because this is traditional, and from history the bone blocks have been used for many years, and this is how I was taught to come over situations like this: a patient losing traumatically the central incisor, as you can see here. Yeah, and this is how we did this for many years, a cortical bone block from the ramus, and everyone that is doing this knows how hard it is to adapt it properly to the underlying bone, and a lot of work to do, and still putting some bovine bone on top of it, as you can see here, the adapted cortical bone block from the ramus, and try to adapt it nicely. A lot of work, but still after half a year you can see the bone block is somehow integrated, but doesn't look that nicely. And you can install the implant, but you never know anything about the fate of this cortical block outside. So yes, it works, and this is 10 years after the whole procedure, and it's still working nice. Also, the implant still in a nice position, and we know it works. But other techniques came up, and so the indication for the bone blocks, as here outlined by the ITI, is more alternative technique. So the GBR is one of the favorite techniques, at least recommended by the ITI, but still in the aesthetic zone, bone blocks are an important tool to work with. And you can see the shell technique is not that emphasized in the recommendation for single tooth restorations. It's a little different for situations where you have extended gaps. The more complicated the defect size or the defect situation is, the more bone blocks come into account. And the shell technique shows up here also as a preferred technique. So one of the reasons that might be is that the bone block is difficult to adapt. Yeah, so the GBR seems to be easier. Although in literature, we know that the bone blocks have lower complication rates compared to the GBR, especially when it comes to vertical defects. But yet, GBR techniques were much more popular. And I think one of the reasons is that the cortical bone blocks have an unpredictable remodeling, as you can see here. Here you have a nice integration of such a cortical bone block from the ramus, but here you see situations where it is somehow integrated, but not completely regenerated. And this is something that might cause that people refrain from this technique. But what we know from literature now is that allogenic bone, especially bone blocks, perform the same good as autogenous bone blocks from the ramus or from other annual parts, except for vertical augmentation, there is the calvarial bone blocks, they perform better, but I don't have any patients that want to have calvarial bone blocks. So we know allogenic bone blocks perform the same as autogenous bone blocks. So we have now a tool where we have good options to overcome this unpredictable remodeling. And we know that the implant success rates are the same or even better compared to implants in autogenous bone blocks. So now we know that we reliably can use allogenic bone blocks, and let me show you an example in like here, also a traumatic tooth loss of the central incisor. You can see here that we have a defect, and it is a class 3 defect. That means that we have horizontal and vertical bone loss. And you easily can now bring in the cancellous bone block, the maxgraft bone block, and fix it with a screw. And you can see that we try to stay in the alveolar ridge and not to over-contour it. And here the post-op X-ray, the outer lining with the bovine bone. And yeah, we try to reconstruct the alveolar ridge. And this is when we come back after 6 months. You can see we have a complete remodeling of this situation. And this is the outer lining. You can remove these particles or even can bring in some more of the bovine bone just as an outer lining to try to prevent from resorption. Well, as you can see here, we have a complete remodeling. So now I think we can be encouraged to use bone blocks to reconstruct those situations, and we get good aesthetical results. And well, so one more reason that people say, well, allogenic bone blocks, they don't work that properly, is the publication of Xiaoshu, because he wrote about complications related to allogenic bone blocks. And he reported of about 7% of complete loss of bone blocks, partial loss of 8%, exposure of the membrane in more than 30%, which is a lot, the perforation of the mucosa in 14%, an infection in 18%, and the complication rate in the mandible is even higher, which might be an important hint for later. But if you see those data, yes, of course, you might not be encouraged to use allogenic bone blocks, but let's compare these data to autogenous bone blocks. For horizontal augmentation, in summary, you get up to 10% complication rate. And when you have a vertical augmentation in advance, then you have a complication rate of up to 30%, which is comparable to that of Xiaoshu with the allogenic bone blocks. So now I have to be honest, because I didn't see so many complications using the maxgraft bone blocks. And that is why we started another investigation with the own cases. And we recently published that. And so we investigated more than 150 allogenic bone blocks, maxgraft bone blocks, and compared them to autogenous bone blocks, mainly from the ramus. And you can see that those two groups don't differ a lot. But if you have a closer look, you can see that in more challenging situations, it seems that I preferred the allogenic bone blocks. At least this is what you can see from the data, like here in class 3 and 4 situations where you have vertical augmentation, I preferred the allogenic bone blocks. As you can see, that medication didn't influence the success of those bone blocks. Yeah, and so we investigated a lot of factors and tried to see why or which risk factors do we have for any mistake or any failure. And so this is actually the number of complications we have. And you can see that with the allogenic bone blocks, the maxgraft bone blocks, we only have 8% complication rate, which is pretty low compared to the autogenous cortical bone blocks, where you have almost 20% complication rate. And most of the complication is related to partial bone block loss or a wound dehiscence. So the number is much lower than it has been presented in the past. So we have only 8%, at least in my clinic. And when we did the multiple regression analysis, then there was at least one factor that influenced our success rate. And this was the overcontouring. And if you think about publications that still encourage us surgeons to overcontour at the augmentation process, for example, in GBR, or if you see the L technique or whatever. So I don't think that this is successful, because in our data, the overcontouring led to failures. So you should stay in the dimensions of the alveolar ridge and don't overcontour too much. We were also able to find a threshold where the complication might occur, and it was at a height of approximately 2.5 millimeters in the vertical distance. So you should not exceed the height of the alveolar ridge of more than 2.5 millimeters, because then there is a risk of failure. And you can see that here, that especially when there is the vertical dimension and you exceed the alveolar ridge by more than 2.5 millimeters, the number of complications is increasing. Here you can see it even better. Here, the autogenous block, if you don't have any overcontouring, you don't have complications, at least in our data. But if you do overcontour, we ended up in almost 80% complications. Other way, with the allogenic bone block, yes, we had some minor complications, even if we didn't overcontour, but on the other hand, we didn't have that much complications when there was overcontouring. And I'd like to show you why this might be. We have here two cases that are pretty much the same. Both have a vertical resorption and a horizontal resorption. And here I used a monocortical allogenic block, maxgraft block, and here a cancellous block. And don't laugh, because these were one of my first cases with the maxgraft blocks, and I thought I have to overcontour. And this is what happens. So here you can see that the cortical part of this monocortical block lies outside the alveolar ridge. And I did the overcontouring right in the horizontal dimension, both, and the vertical dimension, and the same here with the cancellous bone block. And what happens, I think you know. So we have this dehiscence and a partial loss of this bone block. But we were lucky with the cancellous bone block. The screw didn't show through the mucosa, and the underlying bone or the surrounding tissue was able to somehow reshape this and resorb the overcontouring, at least a little. But here the cortical bone couldn't be resorbed, and so we have this dehiscence. But we were lucky because the cancellous part of this bone block reshaped, and so we had a reconstruction of the underlying bone. But you can see the major problem is if you overcontour a cortical block, it might end up in a dehiscence, in a wound dehiscence, and a partial loss of this bone. So you should avoid overcontouring. And there is no need for overcontouring because we investigated the behavior of cancellous maxgraft bone blocks compared to autogenous bone blocks from the ramus. So we compared a cancellous bone block with a cortical bone block. And so we tried to measure it in cone beam CT scans, preoperatively, postoperatively, 12 months. Here you can see what we did. So we measured the volume right before augmentation, after augmentation, and then after the follow-ups. And these are the results. So there is no difference in the behavior between the cortical bone blocks in black and the cancellous maxgraft bone blocks when it comes to resorption. So there's almost no resorption. And so it behaves more or less like a cortical bone block. So we don't have to overcontour because we don't have to expect too much resorption. When it comes to vertical augmentation, there was no statistical significant difference. So it behaves pretty much the same, although the cortical bone block might be a little more stable, but anyway, there was no statistical significance. So there is no need to overcontour the situation. Try to stay inside the dimension of the alveolar ridge. So, and many of the colleagues asked what happens to the bone block. So will it stay there like bovine bone, or is it completely regenerated? So I'd like to show you those results. A patient suffering from a multiple tooth loss on the right side in the upper jaw. And you can see a massive horizontal resorption. And of course, you can use larger bone blocks to overcome this. And then you're gonna fix it with 2 screws. And I like to use the membrane here, adjacent membrane, to cover the whole situation. And although we used a large bone block, you can see I tried to stay in the dimensions of this alveolar ridge. And here you already can see how nicely this bone block is integrated into the at the underlying bone, and it is regenerated. And when we come back after 6 months, you can see the screw, so there is almost no resorption. And what you can see is the outer lining, so those bovine bone granules outside here. Yeah, and you can place the implants, and yeah, it works. 5 years later, I had the chance to take a biopsy right in the area where the implants were installed and where the augmentation took place. So we wondered what happened to the bone, and you can see we have nice lamellar bone. There are no remnants of this former allogenic bone block. We have a vital bone. You can see it here. The blue line is an osteoid line, and you have vital cells inside that bone. So this is vital lamellar bone, and the bone block completely regenerated and no remnants left. So this is like natural reconstruction of the alveolar bone. So how to do? Here we have a through and through defect, and of course many techniques might be available. I like to use the bone blocks in those situations, as also recommended by the ITI. And first you grossly adapt the bone block, yeah, and then fix it with a screw, and you can just bring in some granules right here in those gaps. And then you do the outer lining, yeah, and to try to improve the avoidance of any resorption. There is no evidence in literature for that, but well, a lot of colleagues do this, and I follow this because I have a good experience with this technique. And you can see that I try to stay in the dimensions of this alveolar ridge. So the bone at the neighboring teeth is my reference. And I try to stay here, both in the vertical dimension and in the horizontal dimension. And then I cover the whole situation with a membrane, here the adjacent membrane, and I like it a lot because it adapts very well. It's not sticky and it's very thin. So I like that membrane. And finally, on top of the adjacent membrane, I prefer to bring in a PRF membrane just to improve the soft tissue healing. And since I do this, I don't see a lot of complications with soft tissue healing. So, and then sutures, and that's it. So we know now that the bone blocks are very reliable when you stay in the dimensions of the alveolar ridge. We have a complete remodeling of this bone block, and so get really nice results. But there are difficult situations where also the consensus conference of the ITI is a little warning where they say in the mandible, the allogenic bone blocks might not work that good and data are missing. So I'd like to show you such a case where I do have sometimes problems because it's difficult to work with the blocks, but it works in the end. So here you can see a major resorption of the mandibular posterior alveolar ridge. And here in the cone beam CT, you can see you have a very thin alveolar ridge, and the defect is shallow. Yeah, so it is not easy to really adapt a bone block here very nicely. And you can see, well, at least maybe I didn't do it very well, but it's not that difficult, not that easy. A very thick block. So I went over the contour of the alveolar ridge, and I went over in the vertical dimension, also over the bone from the neighboring teeth. So I did a lot of mistakes in this case. Anyway, you can see the screws here, and if you remind the screws, you can see after the augmentation. Here it doesn't look that bad, so it seems that we nicely reconstructed the situation, but there is overcontouring here. Yeah, and also in the vertical dimension, as you can imagine here. Yeah. And so after 5 months, you can see, yes, there is the integration of the bone block right in the dimension of the alveolar ridge, but outside there is not vital bone. Also in the vertical dimension, we have to remove some of the bone because this will not be vital bone. And there is resorption, as you can see here with the screw, we lost, there's a partial loss of this bone block. And as I said, it is not easy to adapt such a bone block on a shallow situation. And we were able to install implants, and it works, still works. We have here some loss, but it's still no inflammation or bleeding on probing. So everything is fine so far. But anyway, I'm not happy with this situation. And these are the cases where I came to the technique with a shell technique. And so let's go to that. The shell technique, unfortunately, is not in the focus of the ITI, or at least in this old treatment guide. And it was only introduced in a single tooth gap when there is a combined horizontal and vertical defect. Then it is mentioned, and if there is extended gap, then the shell technique might be a preferred technique in this combined horizontal vertical defect. But I think if you get introduced to this technique, I think you can use it in much more indications. And I'd like to show you why. But first, let me tell you something about this technique if you don't know this technique. Well, the maxgraft cortico is used for the shell technique. And this has been the work of Professor Khoury for many, many years. And it is also known as split bone block technique or cortical bone lamina technique. And in the end, it is somehow a combination of a bone block because you have this rigid cortical shell outside and it is fixed like a bone block, but you fill up the gap with the granules. So somehow it is a combination. And Professor Khoury did a lot of these cases. And he is very experienced on that. And you can see in his publication, he had a retrospective investigation on more than 3,800 bone blocks from the linea obliqua, from the ramus. And his surgery time to take this bone out is about 6.5 minutes. So I can make that, but he is well experienced in this. But anyway, although he is experienced, he has some nerve disorders, which I'm afraid of, because as you heard, I'm from Austria on a rural side. And if there is any patient having nerve damage more than 1 year, so a lasting nerve damage, this might be a problem for me in my daily work. So I was not happy with this technique for many years, but then Bottis came up with a maxgraft cortico. And so I rethought my whole work, especially for those cases in the mandible that I showed you before. And I was encouraged also by Jochen Tunkel, because he showed in his work that the results compared in a split mouth design, the results from autogenous shells or from allogenic shells are pretty much the same. So there's no difference. And he encouraged me to use the allogenic bone shells, so the maxgraft cortico. And well, it's a nice technique, especially for those cases I showed you before. And now let me show you this case here, a similar situation that we had before, but there is one teeth left here. And you can see this massive horizontal defect. And yeah, we have to reconstruct it. And again, it might be pretty tough to really adapt bone blocks nicely. And here a shallow defect. Yeah, so this is the indication, the classic indication for the shell technique for the maxgraft cortico. And you can see the defect here, and you place this maxgraft cortico right at the bone and try to stay in the dimensions of the alveolar ridge. We have the same rules here, and you're gonna fill the space in between with the granules. And you might use granules, bovine granules, allogenic granules, or you could even take with a safe scraper some autogenous bone and fill it, the container we call it, that is created by the shell. And here you can see the post-op scan, and you can see that the alveolar ridge nicely is reconstructed here, and the gap is filled here with a combination of bovine granules and allogenic maxgraft granules, and the situation like that. And then at the control, 4 to 5 months later, you can see a nice integration of those granules right in a container. And here the shell still visible, of course. And so we also have a nice reconstruction of the situation. The re-entry, nice bone in between. And here you can see something that I should mention, that the position of the screws here is also decisive for my result afterwards, because you can see the screws have been attached pretty much cranially. And that means that the cortico, the bone plate, is now pushed a little to the lingual side. So we might have gained a little more space or a bigger container if the screws would have been placed a little more caudally. And so this is something you should take into account when you place your screws and when you create the container. And yes, it works. So you have the implants in place, and you have a very good and long-lasting result. I think the shell technique is also perfect in situations where you have scarring tissue. Like here, because here GBR might not be that easy, as this soft tissue is very dense and brings a lot of pressure on the underlying bone. So we have to think about the shell technique. And we have here this horizontal deficit. It is not that much, but You could think about simultaneous implantation and GBR, but as I said, the soft tissue is not that nice and it is scary. So one should think about a two-stage approach. And so we did. You can see here the maxgraft cortico in place. And in that days, I filled up the container with bovine granules. And in a minute, I'm gonna show you, in a minute, I'm gonna show you what that means or what the result might be. And what you can see is I tried to stay in the dimensions of the alveolar ridge. It's the same rule as with the bone blocks. And as this maxgraft cortico has a thickness of 1 millimeter, we try not to exceed too much to the outer side. So that is why we flattened the edges to bring it a little closer. And here you can see the different fillings of these containers. This is with autogenous bone in the container. Here you have the bovine granules, and here you can also see a fracture, but in a minute I'm gonna show you if this is a problem or not. And here the bovine granules, here the combination of maxgraft granules with bovine bone, and here finally only maxgraft granules. And the regeneration of this container is pretty much perfect with the autogenous bone, but also with the maxgraft granules, as you can see here. We have a perfect regeneration. If you have a combination, you can see a much more dense tissue in the container. Yeah. And with bovine bone alone, yes, you have hard tissue, but it is completely, there is only the ingrowth of the bone into the bovine granules. And so it depends on what you want to have or what you expect. So far, there's not a lot of evidence of what is the long-term effect of what you bring in here. So some colleagues, they prefer to bring in autogenous bone with allogenic bone. And when the re-entry occurs, then do the relining with bovine bone. So still there is not a common treatment guide on the situation. Personally, I prefer allogenic bone so far because you have a perfect regeneration of this situation. Here with the bovine bone, you can see it reminds you somehow of the GBR, where you still have some remnants of this granules, but there is also bone in between. And yes, that works. You can bring in the implants. And finally, you have a nice result, although you have a minor soft tissue surrounding here, this area. What is the difference between those two techniques? Somehow you have, as it is called, split bone block technique. You have, of course, some common things and common strategies, but there is, in my opinion, at least two major differences. The rehydration of the maxgraft cortico is highly recommended because if you put it, when you start your surgical treatment and you put it into saline, for example, or you can put it in PRF or whatever you think might be a good option, but you should rehydrate it because then the properties of this maxgraft cortico get much better and it is not that brittle and might not break that easy. You have those 1 millimeter in 1 millimeter thick maxgraft cortico, so it might not fracture that easy, but when you rehydrate it, it is very nice to handle. personally, I don't rehydrate the cancellous bone blocks extensively because as they are not all the same, so because they are from different persons, and sometimes they are more brittle, sometimes they are more spongy, and if you rehydrate it too much, it might get very soft, and so you can't bring in a screw because it might drive right through the block, and so I don't rehydrate it too much. Another difference is the fixation technique. When you do the fixation, then you need a lag screw for the bone block. That means you want to compress the block right to the underlying bone. And so there is one screw necessary for a smaller block. Of course, if you have bigger blocks, you need maybe 2 screws, but there is not a risk of rotation or anything. So there is one leg screw at least necessary, but when you come to the maxgraft cortico or the shell technique, you need 2 screws because you have just adjusting screws. That means you don't want to have any compression on the bone shell that might press this shell to the underlying bone. You just want to keep it in place by 2 screws, and there are 2 screws necessary because you don't want to have a rotation of your cortical plate. So this is one of the major differences you have in the handling. And so far, there's not much literature about it. And we have a nice working group. And I'm happy that I joined this group. And you can see with Per Kemmerer, Jochen Tunkel, Robert Würdinger, and Andreas Papst. So we published recently, and it's open access. So if you're interested in, you can have a closer look on that. And we put our cases together and published it. And here you can see one of the typical cases. Here the cortical plates in place. You fill it up here with maxgraft granules, cover it with a membrane, and then finally at the re-entry. And as I said, some of the colleagues, they do the outer lining after implant placement just to try to prevent further resorption in the future. But what is interesting, so we had together had about 372 cases and installed in the end more than 600 implants into these situations. And I think it is very interesting because we had only 4 implants that failed because of peri-implantitis, and the number of complications is 30. And I think this is not that much. So we are also in an 8 to 9% complication rate, which is pretty low for augmentation procedures. And most complications were also some dehiscence, where you can maybe wait and don't remove it immediately, the plate or the granules underneath. And we only had 3 or 4 fractures of the cortical, maxgraft cortical. So here another case where you can see how to handle a patient suffering from traumatic loss of this central incisor. And you can see we have a vertical defect and a horizontal defect. And we had to remove this lateral incisor as well, because you can see it was affected by that trauma as well. So we had to remove it also. And you can see the defect here. Here we did some ridge preservation with the maxgraft granules. And here, to cover this defect, we put in the maxgraft cortical. And the shape of this maxgraft cortical is not rectangular. It is more like a U shape, yeah, to really nicely adapt it. And you can see we try to stay in the dimensions of the alveolar ridge, not to put it too far out of the box, let's say. And you have to keep in mind that this cortical strut is not, you should not count it to the space where you can place the implant. Yeah, you should keep at least a little distance when you put the implant in to this regenerated area, and keep some distance from this cortical strut. And here, after 4 to 5 months, completely regeneration of the maxgraft granules. Yeah, it is a nice a reconstruction of the alveolar ridge. And the fate is, after that short term, after about half a year, you can see we still have some remnants, of course, of the maxgraft granules, but already new formed bone around this, and it will be resorbed after a time. We have vital bone, as you can see here, living cells with the osteoid, and so there is an ongoing process and a nice reconstruction of the alveolar ridge with living bone. And those remnants, as I showed you before, after 5 years, will be removed by the local bone. And now it seems a little bit confusing, but meanwhile, after 6 years, the patient showed up and we had to take those two teeth out, and that's why it looks a little funny. But here you can see the result. After 6 years, we have a nice soft tissue situation, and I think the patient can be quite happy with this restoration. So again, how to do the shell technique? Well, here you can see a horizontal atrophy of the mandible, as I showed you before, and it might be pretty tough to do this with bone blocks. So this is, for me, a perfect indication for the shell technique. Of course, you have to nicely open up the soft tissue and release it, and then you can prepare the maxgraft cortico outside, and especially in the posterior mandible, mainly the cortico looks like a wing of a bird. Yeah, and so it fits properly. And if you use this trimmer, this is a nice tool, because to keep it in your hand, it might fracture, and here you can just in this trimmer and bring in the holes or shape it, so it's a nice tool. And then I highly recommend to make the holes before you further process the local bone, because you will find those holes later on again, and then you can fix it later on very easy. I like to make something like a gutter here, because then you can really nicely bring the maxgraft cortico here, and it's not slipping away in the apical part. And then you make some holes for the bleeding. I prefer that, because then the healing characteristics are much better. And then you're gonna fix 2 screws. And as I said before, they are adjusting screws, so you only need 1 drill and not 2 drills as you have with the bone blocks, and just to keep it in place. And then make sure that you remove sharp edges before you're gonna fill the container here, because otherwise you wash all your granules out. And I do it with a diamond burr, because then you might not fracture it, because other burrs might harm the cortico, and try to remove those edges, then fill up the space in between. And then we can discuss about it if a membrane is necessary or not. Some of the colleagues in our group, they don't use membranes in those cases, like Jochen Tunkel. He says he puts some autogenous bone granules just on top and doesn't need any membrane. I prefer membranes, But anyway, the most important and the decisive thing is the wound closure. As always, when you do augmentation procedures, try to take any tension out of this of the wound and close your wound. So, and here a case where actually I did both, because this patient showed up first losing the central incisor again. And yes, you could do it with many techniques, single stage or two-stage approach. I prefer the two-stage approach in the aesthetic zone. So here we have a vertical deficit and a horizontal deficit. So after removing all the soft tissue, you can see this bone block is not that small, but we try to stay in the dimensions of the alveolar ridge, both vertically and horizontally, and fix it with a lag screw. And here again, you can see how we stay in the dimensions of the alveolar ridge. Then the outer lining with the bovine granules, you can see this outer lining right here, just a thin layer on top of this bone block. And then after 4 to 5 months, we have a nice regeneration again. And here, after 6 months, coming back to our block, we have a perfect regeneration of the situation. And when you have a look to our osteocentesis screw, you can see there is no resorption, as I showed you in the data before. Still, you have those granules outside. You can remove part of them. And so the result is quite nice. But the patient, meanwhile, suffers from another problem in the lower left mandible. And you can see here the shallow defect, which has a horizontal defect. And again, yes, this is indication for the shell technique, maxgraft cortico. And here you can see that I don't adapt the cortico in the beginning tightly to the underlying bone, because if you leave some space in between, it's easier to fill the container with the granules. And after filling the container with the granules, then you can fix the screws more tight. So the maxgraft cortico comes into contact with the bone. Try not to exceed the bone of the neighboring teeth. Yeah. And as I said before, I prefer to use a membrane like here, the Jason membrane, and fix it here with a suture. So we have everything in place. And then the postoperative scan tried to reconstruct the alveolar ridge here. And after 4 to 5 months, a nice regeneration. Here is a mixture of allogenic and bovine bone granules in the container. So it looks much more dense and not that the perfect reorganization in the container as you have when you only use maxgraft granules. And here the final situation. I think we have a nice reconstruction. Well, so to summarize, we have with the allogenic bone block and the maxgraft cortico perfect tools to reconstruct the alveolar ridge. And there is a perfect reorganization. When you compare it to bovine bone, you have really bone that you gain, and you have stable situations for many years. And both are, so they are different techniques, but the rules for those techniques are the same. You should stay in the dimensions of the alveolar ridge and try not to overcontour the situation. The overcontouring is the major reason for failures, and both techniques are reliable. And as you have seen, I prefer the shell technique, especially for defects that are very shallow, like in the posterior mandible, very often when patients lose a bridge or something like that. And also if the soft tissue is of a minor quality, I prefer the shell technique. and the bone blocks whenever, so is my favorite because I can see perfect results with this technique. And so I think I'm pretty good in time, and I'd like to send you some greetings from where I sit right now, because here where the arrow is now is the house I'm sitting right now. So in the middle of the Alps, by -10 degrees, as I told before. So now the question is, I hope I say it correct, hay una pregunta.
Dr. Klaus, thank you very much for your lecture. I don't know if Dr. Janet, can you make him the questions that is on the chat, please, or I do it? Okay. So I will do the questions here. One question said that if you cut the cortical, or if you someone cut it for you, depending on the tag you take to the patient.
Yeah. So the cortico, I do it always on my own, right at the patient. So far, there is no possibility to get individual maxgraft cortico so that someone else is doing that for me during the planning. But this is something I do right in the surgical process. Yeah.
Okay, and the other question we have here is the cortical of the cortical. How much does it last? Because in all the cases, they can see that have like a little sheet of the cortical without remodeling.
Yeah, the cortical will remain there, and it will remain for many, many years. So there is a creeping substitution. And yes, after many years, in really a small number of patients, there might be a loosening of this plate after many years, but mainly there is a creeping substitution over the years, as we know it from cortical bone blocks, where you have this, it is called creeping substitution over the years. So if you come back after 6 years, you will see less of the cortico.
Okay, I want to ask you another thing is, you talk about membranes. You always recommend to do this technique with JSON, or which membrane do you think it's proper to do this?
Yeah, so personally, I love the JSON membrane. That's why I use it, yeah, because, but of course, any membrane might be. So I think you could use also something like a permanent, but it will not be easy to fix it that around your augmentation. So the JSON is a membrane that nicely adapts to the underlying bone, to the new formed bone. But of course, you could use any other membrane as well. But it's my personal choice because I really love this membrane.
Okay. I have one other here, is that cortical, it's about the cortical that remain there. If that cortical that remains can't act like como un secuestro, like it get into the bone, like it happens at first with the allogenic blocks, like the J block. I don't know if you understand me the question.
I hope I got it. So you mean if we don't have the cortico in our defect, so well, maybe I try to answer.
Can that remaining cortical act as a sequestration, like happened before with the allogenic blocks, the J block?
Yeah. Okay. Yeah, there might be sequestration. Yeah, but you don't see it very often. So I talked to a lot of colleagues that used, so with the allogenic, with the maxgraft corticos, so far, I don't know any case. But we know it from autogenous shields that after 6, 7, 8 years, there is some sequestration. But so far, I know only 2 or 3 cases when I discuss with the colleagues. So this is really, really seldom, a rare situation.
Okay. So far we don't have more questions. I want to thank you for your lecture, for your time. I know there is very late and very cold, but thank you very much for your lecture. For us, it's a pleasure to have you here. For me, a pleasure to see you again and to have a lecture for our colleagues here in Colombia. So Dr. Claus, thank you very much for this.